Hi everyone, we're going to get started now. Today we have Dr. Williams, Dr. Heyer, and Dr. Brown. This briefing is on record for 1 hour. Dr. Williams and Dr. Brown will give some remarks, and then we'll go over to the phone lines. One question, one follow-up. I'll turn it over to Dr. Brown now.
Thank you. We're here today to present some information really about restating some of the numbers that we've been looking at, talking about what are very clear accelerating trends in all of the indicators of the spread of the pandemic, to present what is a more worrisome and challenging and dangerous picture than we would have presented a week ago. The first thing that I want to touch on is restating or looking at the numbers about the case growth in the province. When we presented numbers last week, we noted that this was starting to parallel the worst case scenarios that we were modeling, with about another, we believe, 800 cases attributable to a backlog in testing. This number is now higher, and the curve continues to increase in terms of its steepness. The second thing I want to note is that we are seeing a dramatic growth in the percent of tests that are positive. So the number of people who have a test, the number of those tests that come back positive is also growing. It's over 2% right now. But perhaps even more important is that we see an increasing trend of positivity in tests for people who are older. And it's there in that older population where both the consequences for health and the consequences for the health system are most severe. To provide a little more information on this, we were seeing substantial spillover earlier on, but when we look at the population and exclude those under 10, where the rate of positivity is lower, you see a sharper increase in positivity. And when we start to look at, say, people over the age of 60, that rate of positivity is now 1.4%. That is more than a threefold increase across that same group compared to the last week of August. So cases growing, and actually growing faster than we initially stated last week. The percent of tests that are positive growing again in a very sharp way. And this is all against the background of relatively consistently strong testing numbers, which when we see a situation of high test numbers, high case and growing case numbers, and high positivity, that tells us we are very clearly in the middle of a second wave. I want to also talk about, not just those leading indicators like tests and the percent of those tests that are positive, but also touch on the rate of hospitalization. As most people realize, one gets the disease, develops symptoms, and then those symptoms worsen to the point of requiring hospitalization. Really over the last 3 weeks now, looking at that lagging indicator, that indicator that changes later, of hospitalization, that is now at about 250% growth over the last 3 weeks, 249% to be specific. This is a substantial increase now both in our leading indicators like cases, but also in our lagging indicators like hospitalization. This also carries implications for ICU use, for intensive care unit use. And we look at intensive care unit use because it's a very firm, hard indicator. However, it is, other than mortality, really our lagging indicator, the one that will change latest because there would be the worsening of symptoms, the entry into hospital, and then the entry into the intensive care unit. In all of our scenarios now, both our best case scenario and our worst case scenario, the number of ICU beds occupied by COVID patients crosses the 150 bed threshold. This is the threshold where we believe that we begin to see implications for the ability to provide other surgeries in hospitals. And in our worst case, all of these actually cross that threshold within the next 30 days. And in our worst case scenarios, it crosses other thresholds that really lead to the reduction of access to hospital care. The importance, though, of understanding the spread goes well beyond its implications for hospitals. Obviously, there is, when people are hospitalized, when they're in the intensive care unit, that is the population where we're going to see probably the highest mortality rates, but they also force out or squeeze out other care, both immediate important care like surgery for cancer or surgery for heart disease, but also preventive care and access to other care. Moreover, when we see the rising rates in the community, we also see rising rates in places like long-term care homes, where our most vulnerable are. And we're now starting to see that rise in cases, not a significant rise in mortality yet within long-term care homes, but a rise in cases in long-term care homes, both for residents and for staff. And we know that the community spread is the single best predictor of adverse outcomes and deaths in long-term care homes. However, this is not, I'm presenting statistics for the entire province that present a very threatening or worrisome picture. This is not universally or equally spread out across the province. In the 3 or 4 public health units that have the highest rate of growth, you can see a very, very, very steep trajectory of all of these indicators, looking really kind of at that point like where the hockey stick turns and starts to move up. If you look at a more middle risk of our public health units, there is a growth, but it is a more gentle curve. And if you look at the remaining public health units, roughly a third to a half of the remaining public health units, it's a very flat curve still in terms of these indicators. What this tells us is that you really don't want to do anything at a province level at this point. You do need intervention, but it should be more tailored to the level of risk in the public health units that we're looking at. I think also important to kind of look at what is happening around the world right now. Virtually every jurisdiction is dealing with a second wave. Many of them entered this second wave long before we did. And there's a clear pattern in the way that jurisdictions intervene in that second wave that determines either whether it gets out of control and rises really at a continuing exponential rate until it leads to a full lockdown, or whether they intervene earlier with hopefully a shorter and a less harsh period of interventions. And you can contrast the experience of countries like Germany with those of Australia, and you can see a sustained and early intervention leads to at least as far as we can tell in the data right now, a lower level of a surge, lower obviously levels of implications for hospitals, long-term care homes, and mortality, and also less harsh restrictions at that point. Even countries that have been holding out, for instance, like the Netherlands, have recently reimposed a series of restrictions that will be very similar to those that will be discussed later on today. Trying to hone in, though, and look more carefully at where these infections are coming from. We've been looking at data from public health units, like that from Toronto, and it's pretty clear pattern, again, in the data that helps us understand where it's most important to intervene. First, the vast majority of the outbreaks, as at least of October 5th that we had information on, were clearly occurring in community or workplace settings. Essentially, and this is I think the key part of what this data shows, those settings where it is indoors, it is difficult to consistently wear a mask, and it is difficult to consistently physically distance. And I think it's important to kind of note those 3 elements to what we're looking at here, because there is, at this point of growth in the epidemic curve, there is not the opportunity to either test more or contact trace more as a way to suppress or control the epidemic. At this point, it really requires public health interventions to break that chain of transmission and allow the numbers to come back down, where case and contact tracing and testing become a very critical, as always, very critical, but can become a stronger part of the set of interventions. When we look, though, within the Toronto data, that community and workplace setting, and we break that down further, there's a significant number as well that occur in dining, bars, and entertainment. Gives us an idea where some of the discourse has been coming from the last little while. But again, it's again this sort of strong transmission as we look across public health units in those places where you cannot physically distance consistently, where you are indoors, and where you cannot wear a mask consistently. I'll also add that we've tried to understand recent reports out of the Centers for Disease Control, a little bit of small case control study that actually tried to understand this, and this confirms this view of the importance of these sorts of challenging indoor settings as a primary vector, as a new piece of information that we've got now. What I'll also say, though, is that at least again looking back, say in the Toronto data that I already talked about, the lowest source of outbreaks was actually schools, suggesting that although children can transmit the disease very easily, those are not the sources of the outbreaks, and that those are actually relatively staying under control. What I think this means as we look forward, or what we believe this means when we look forward, is that every jurisdiction around the world is facing a second wave. Jurisdictions that are intervening earlier are actually getting better control over the pandemic or the epidemic within their country. And in the setting of Ontario, we can look at the highest risk settings as places where we can probably keep schools open, but significantly restrict those areas where there is strong amounts of indoor time with the opportunity for transmission because of difficulties in maintaining public health interventions. and urging people to stay at home in those high-risk regions unless they need to be out for essential reasons may, at this point, give us a chance to actually get on top of the current spread of the epidemic, and as well in those sort of intermediate risk areas, getting ready there so that hopefully they do not convert into high-risk areas, but if necessary, converting them into high-risk areas with the same restrictions. We would argue that schools can stay open. It will be important, though, I think, to understand the nature of the transmission of infection in schools a little bit more, where we do see outbreaks, and there's some further studies that might help with that. With that, maybe I'll turn it over to Dr. Williams.
Thank you, Dr. Brown. And as I said in our media earlier in this week, that advice coming from the scientific table and from the modeling experts from Dr. Brown and his teams has been most valuable, as well as from our public health measures table. And I had received recommendations from them. We also then went to the health units and asked them for further information and data that would support the areas that they were concerned with, and with consultation. So as a result, when we're taking some changes now, and my advice up on that was on 3 grounds. One is, what do you do with those health units that are in the highest amount of cases per 100,000 that have gone up very rapidly and very quickly, and that irregularly every week now, every day, comprise about 71% of our total numbers in the province. And as Dr. Brown has alluded to, it's not homogeneous throughout the province. It's very much varied in area to area. So we have ones that are basically fairly quiet and acquiescent at this time. We have ones that are in this middle ground, and we have our 3 top ones being Toronto, Peel, and Ottawa that continue to go up very quickly with their cases and numbers and counts and percentages. So at Ottawa, when cases per 100,000, for example, has gone from 54 to just under 62%, or 62 per 100,000. Toronto went up quickly from 70 to 71 from 58. So these are rapidly moving, whereas some are way down low at a lower level. That's just only one metric that we use to look at and watch this happening. The case positivity, also concerning, that while the province was at before around about 1.2, 1.3, it has moved up to 2. But even those areas we're concerned about, they have moved up from 2 to 3% positivity throughout Toronto, throughout Ottawa, or throughout Peel and Ottawa close behind. So these are very concerning, and this is data that has supported us in that way. So as a result, our advice is on 3 grounds. One, how to deal with these high level ones, and we've made very specific recommendations that I'll note in a moment to deal with the issues that Dr. Brown has noted, where there's indoor congregate type settings where wearing masks continuously and consistently has not taken place. I will add that if everybody had adhered to all our public health measures around distancing, mask wearing, staying at home if you're ill, social circles down to the details, and that these type of steps and public health measures would not have been necessary. And it's our hope that throughout the rest of the province, besides the ones we're recommending moving in some direction now, if people adhere and follow those in all these settings, we may not need to take any further steps in that matter. Because as Dr. Brown alluded to, you can't test yourself out of it. You can't case contact your way out of it. You can, by adhering to standards, keep yourself out of it. And that's what we want to see, and we want to see that happening in the next number of days. The steps I'm asking, the measures I'm asking, is in the next 28 days, 2 incubation periods, we're going to be asking our high-risk places to step down to a modified stage 2 level. That means certain recommendations we're going to bring forward consistent with what the modeling group and what the scientific table has put forward. And I'll mention some of those to you at this time. We're going to be asking to look at those venues in those 3 areas. And this has been supported by the local medical officers of health, where they have evidence of outbreaks and concerns, and where they have not seen consistent behavior, and they want to restrict that at this time down. And I want to restrict that from our public measure table and also from the recommendations of the scientific table to look at that. So gathering limits, we still have our thing with 24 outdoor and 10 indoor. We're trying to keep those numbers consistent because some were saying as you varied it too much, people got confused. Restaurants, a topic of big discussion. And as Dr. Brown has alluded to, in the scientific data, they found that there was evidence of, in recent studies, of transmission in restaurant settings, that your risk goes up by 2.8. And so it is not insignificant. So we're going to ask that in those areas that they, while the restaurants stay open, and their patio services, with their pickup and curbside services, that no indoor dining in those facilities for the next 28 days. We're saying that gym and fitness centers, because we've had outbreaks related to group activities, we want that closed at this time in those settings, those 3 places of Toronto, Ottawa, and Peel for the 28 days. And with casino, bingo halls, and gaming establishments, we also want those closed as well. So we're recommending that, as well as cinemas, to stay closed. Meeting and event spaces, they can have 10, a maximum, but we're asking that might be effective to be closed later in the week to make sure that we don't have that occurring in large banquet settings. Performing arts and racing venues, the public closed at this time. We want to keep our schools open. That's why we're saying this does not impact schools or post-secondary school institutions. We know it's important. And part of that I will premise on the fact is that as we get the community transmission down, it keeps those safer for the schools, as Dr. Brown has alluded for. So these are valuable investments. We want to keep it down for our long-term care homes, not to be impacted. So these are investments going forward to keep these institutions safe and open, that we know that data supports the importance. We're also saying in retail services and malls, we want to keep our stores open, but they have to do care and protection as they have, and with spacing and masking and that. We're asking the malls to then switch from their food courts to being sit-in to just being takeout only, and you have to take your food out and other places to eat in that location. We're also looking at things around tour and guided services, as well as open houses or retail things that details will be following shortly. We're also asking not to impact those school functions. Schools in their activities writ large, including child care centers, preschool and post-school, are not being touched. Those are important and critical. But they have very clear guidelines and direction and things to follow and handle those ones, not only in the 3 throughout Ontario, and we want that continued and maintained consistently. We found outbreaks related to team sports. We've asked that that not be taking place in the 3 areas we've talked about. That means contact sports and that. You can have individual training type things and things where you have like children's learn how to skate stuff, but not competition where we've seen outbreaks and activity related to that. And also large other gatherings such as museum, galleries, zoos, and science centers to limit the activities so the personal contact can be brought down under control during this 28-day period. So we have come up with strong recommendations because we have seen that the public health measures worked in the first wave. The difference is in the first wave, we did those on top of a lockdown. We did those on top of schools being closed. We did well. Now, can we do it again with our schools open? Can we do it again with our retails open? Can we do it again with a number of things being there? Can we do it in certain strategic areas in high-risk zones? Also giving a warning to those that are close around that, you may be impacted soon if your numbers go up accordingly. So we need to be focusing back on, because the tool, if we get everybody doing what they should be doing, then the demand at our assessment centers drops. Because if you don't have an exposure, you haven't followed everything honestly, and you have not been exposed and no signs and symptoms, you obviously don't need to be tested. And that decreases the load there, gets it back down, gets our turnaround time intact. Also, the load on our case contact managers drops, because in the first wave, people had an average of 8, 9, or 10 contacts only. As I said in my press conference yesterday, now they're saying quite commonly people have 30, 40, 50 contacts, up to 100 in the last 5 to 7 days. That is totally not acceptable, and it becomes impossible to do all that, as Dr. Brown alluded to. We cannot case contact ourselves out of that. And so that will help to bring that under control and get our turnaround time even better. So these are the things that we're going to be carrying forward on that, to say, in this time, in 20 days, can we ramp this down, especially in these 3 high-risk areas of Toronto, Peel, and Ottawa. And we have been in conversation with their medical officers of health, who are highly supportive, and they are going to work from in their own respective jurisdictions on the areas of priority to continue to drive that down. We have our general messages, again, about public: don't go out if you don't need to go out, don't travel if you don't have to travel. Over 70s and immunosuppressed people, be careful, be cautious on who you're contacting, especially in these high hot zones for the next 28 days. And then the general public writ large, the same message we said all along: do it again, do it well, do it consistently. We've done this before. I think we can do it again now in this second wave. As Dr. Brown said, every sector of the world is experiencing these second waves. let's show that Ontario can do it successfully as well with the data we have supporting us and the scientific evidence as well. So with that, I'm going to hand it over to any comments from Dr. Heyer or for general questions from the media.
So the only comment that I'm going to make is built off my two colleagues, prevention. We want to prevent spread, and we want to prevent that in every way possible to stop people from being sick, stop the potential of it spreading into the long-term care homes and the schools.
Thank you.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
From Ashley Legasic at Newstalk 1010.
Hi there. I'm wondering if you can just break down what essential is classified as. Like, work has been classified as essential, but is that all work that isn't mentioned in today's announcement? What about non-essential businesses like construction? What's the advice for them right now?
So our public health measures, on there we are closing, asked to close where there is indoor gathering, where people cannot, as Dr. Brown has given the evidence for, consistently maintain and have not maintained masking and social distancing. So all the ones we're recommending today to assist in this activity is based on that. So we're not going after selective retailers. There's rules around construction sites with occupational health and safety. The role of the Ministry of Labor has in that function as well. We did not recommend that at this stage here because we have not seen outbreaks in that regard, but we have seen in these interior congregate type settings where, especially in these 3 zones, there has not been consistent adherence to standards. So we are selecting those ones in particular.
Follow-up?
Thank you. And there have been a lot of calls for transparency. The public wants to actually physically see the data that these decisions are being based off of. Why isn't that data being released today?
So the data, and as you can see, Dr. Brown was alluding to all the different data from other sectors of the world, literature and research data. We have talked about there's a variation throughout the province with rates per 100,000, R naughts or REs or RIs and different terms like that. There's growth and rapid spread in how fast it's going up. There's aspects related also to percent positivity in these areas and even subgroups there. There isn't an exact formula. There's things compiled and also the rates of changes, and Dr. Brown may want to comment on that. When you're looking at these flows, and he's alluded to the speed and rapidity of it, and how does it compare to other jurisdictions. So it's not that there is a formula that people can just plug and play. There's a combination of different data points that takes a scientific group and a modeling group like Dr. Brown's group to take that analysis forward and give us recommendations. Perhaps you'd want to comment on that, Dr. Brown.
So much of the data that I shared today is already available in the public domain. There are some of our analyses that we will put out. We're just going through these as quickly as we can, and all of our science table work actually is made transparent on our website, usually a few days after we finish the analyses.
Next question.
From Travis Danraj at Global News.
Hi there, doctors. Can you hear me?
Yes, we can.
Yes.
Okay. What specific evidence did you not have last Friday that Toronto's medical officer clearly had when she recommended that many of these measures that you're announcing today be implemented immediately? And essentially the question is, what took so long to do that, despite the fact that other medical officers were saying, we need this done now?
When we had discussions with the Toronto Medical Officer, Dr. Eileen Davila, on Friday, we heard of her concerns about some of these specific venues. We asked at that time, could we get some data that would support these different ones and give evidence of that? And that was late on Friday, and so over the weekend and early in the week, we were asking them to supply us with that data. We looked at our sources within our own aspects of that data, as Dr. Brown, and may want to comment further, to carry that forward, because in the paucity of some data points, we needed to have some analytics and modeling that the science table and the modeling table were able to give us, and further scientific and comparisons that was compelling and showed us the evidence that we had to move quickly on, and The fact between Friday, remember we were coasting and staying steady around 500, upper fives, and things weren't progressing. We had a backlog in the, and maybe Dr. Heyer would like to comment on that, a backlog on some of the data points in that, and then all of a sudden on Monday, Tuesday, Wednesday, our numbers of positive tests really started going up exponentially in the percent range very rapidly. So we had a number of things together that drove us to the commentary we have today and given advice and direction up for further action by the government.
I think really important to focus on what Dr. Brown and Dr. Williams have talked about as far as gatherings. So a lot of the focus came on to restaurants, but this is about gatherings. This is about people being together. Restaurants take many different steps. As many of you have known who have observed restaurants, they have plexiglass, they have tables separated, they have many hand sanitizer at the table. The staff are very careful to be intersecting carefully. This is about gatherings where people are in close proximity without masks, in a position of more relaxed, with friends, laughing, talking, and sharing some time together, and not unfortunately recognizing that there's likely a greater opportunity and a greater propensity to spread. One of the studies that Dr. Brown referred to was there was a clearly increased risk on a careful analysis of people at a gathering when they're in close proximity. So this is additional information that we've gained together, all of us working together to try to get the best answers to understand what are the approaches that should be taken. These are tough decisions that many decision makers are taking, and many different pieces of advice are required to make those decisions.
Follow-up?
Sure. Yeah, if I could ask a kind of a double-barreled question here. There's been criticism about the messaging and the public messaging when it comes to public health protocols that people should be following, especially when it comes to gatherings, etc. Do you take any responsibility for that? Do you think that you could have been clearer with that messaging? And also on schools, we know the transmission rate is rising in schools. At what point would you consider recommending shutting down schools, and is that on the table?
So on the messaging, I would have to disagree. I think the messaging has been clear. We have been trying to communicate that again and again to the public on that. I think our issue around some things with social circles, that was seen to be handled very well during May and June. And then in July, people had decided to become very liberal with that, and for whatever reason decide to say, set that aside, set aside the 6-foot distancing, set aside the masking in backyard gatherings and social gatherings. So I wouldn't say that the message was confusing. I think sometimes the public is saying, we're having difficulty because we want to reinterpret it in a way that we seem as meaningful. We have changed the messaging recently to say we're going to have to hone back down from the social circles to the household because we really have to ramp down because of our numbers going up. So I think our messaging has been clear. I think what we have to do is in ways we're trying to really address how to get to the various demographic groups, because a lot of our increase was in the younger age group. And sometimes that messaging has been less than clear, and we want to work on that. And so that's that aspect. As far as schools are concerned, as Dr. Brown has alluded to, we haven't seen the evidence of a lot of transmission within the schools. We have evidence of a lot of people coming from the community into the school already infected. And so far, our system that we set up with the Ministry of Education, with our public health units, with our nurses in the schools, has been very quick and rapid to move on those cases. And a lot of the school ones deal with 1 or 2 people that have been contained either through the cohorting and by then moving people out and doing testing. So we haven't seen a lot of transmission in the schools, yet we do have people coming from the community already positive into the schools. And so schools have been closed and schools have been reopened. So that is happening dynamically. And as Dr. Brown said, these impacts of this community, which has impact on schools, is not homogeneous throughout the province. Some areas it's very low, hardly any transmission. 24 over 27, or 24 to 27 have less than 5 cases per 100,000. So they stay low. So writ large movement is not merited this time. So we'll continue to monitor the schools, work on our definition of how we're handling that, seek any areas of gaps of how we're doing case contact management, schools, daycares, preschool, post-school. These are all important, and so far they've been doing well. We got to keep at it. We got to keep vigilant and keep working at it. If the case numbers go down, it becomes less of an issue in the community, less of an issue for the schools.
Next question.
Is from Jeff Gray at the Globe and Mail.
Oh, hi, thank you. I wanted to ask if you can tell us if any advice, any recommendations that you've made or the public health measures table or the science table have made to the government